chairpersons and the organizers, and I thank you for this opportunity to talk a bit about a bird's eye view of what is happening in practice. This is not limited to the pancreas and to the theme of this conference, but in general it applies to the pancreas as well, because it's the organ of the human body. And as all genetic applications apply to the human body, I'll just talk to you about in a short 15 minutes. So it's just about the impact of the Human Genome Project on health, why clinical genetics and genetic counseling becomes important, what a clinician should know, case scenarios, and the way ahead. So there had been the launching of the Human Genome Project 3 decades ago. The genome sequence has been there. The cost of sequencing the human genome has come down so much. You have 1,000 genomes, you have 10,000 genomes for the Genome India project. But actually, if you see beyond, the understanding of how the genome functions has just started or is just evolving, and we are unraveling the functional basis of human disease. So major impacts have been on cancer genomics, rare disease unraveling, pharmacogenomics, prenatal genomics, and precision medicine. So the consequences are that generating a human genome sequence is now trivial. So researchers and health professionals can do that. Reading a human genome sequencing is now easier. Clinicians and laboratory personnel are often doing that, but clinically understanding the patient's genome sequence may not be trivial. So here the role of a clinical geneticist becomes paramount. This is just a case scenario highlighting a 19-year-old lady born to non-consanguineous marriage, is known case of cyclical vomiting syndrome since the age of 9 years, and she presented with clinical indication of persistent abdominal pain and vomiting. So the DDs were cyclic vomiting syndrome, porphyria, and Mingy's. But the whole trouble started when an outside genetic report of whole exome sequencing was bought and shown along with the patient's admission to CMC Vellore, and we were called in as clinical geneticists because there was a likely pathogenic variant in the HMBS gene which causes porphyria, and you can see it's mentioned as a splice variant in exon 6 and intron 6 boundary, but when you look at it carefully, you will realize that there are a lot of queries of this report, whether to confirm the diagnosis as acute intermittent porphyria, whether the involvement of a clinical geneticist was there before sending the test, was any pre-test counseling offered even by the primary physician, what is the impact of the report on the family, do they have biochemical confirmation, and impact on management. So a big query here. And leave alone the patient and the parent's perspective. What is happening? It's all jargon for them. Is it a bad situation? How bad is it? What is the future? Who is responsible? Why us? What to do now? So many questions. So there are a lot of questions in the clinician's mind as well as in the patient's mind, and you are tackling with the likely pathogenic, the pathogenic, the VUS, and you are in a dilemma. So here the role of clinical geneticist becomes paramount because there is the bench as well as the bedside, which has to be bridged by the geneticist, keeping in mind the confidentiality, the privacy, the medico-legal aspects, and the ethics. So once the genetic component is incorporated into a clinical scenario, which often happens because genetics is like the sand in the beach, it gets into everywhere. So you have to relook at the case, you may have to repeat biochemical tests, you may have to reanalyze the genetic report, dig into the raw data by IVG files, reclassify the variant. So that is what was done Once we had this report and this referral, we had to sit together, we had to get the raw files, and the raw data showed that it was not actually in the exonic or the intronic boundary, and it has to be classified as a uncertain significance. So lessons from the case. So know your phenotype, the genetic and the multifactorial and predisposing factors. The criteria for diagnosing acute intermittent porphyria in suspected cases is first biochemical, followed by genetic testing. So read about the disease in detail, but the trend now is that more importance is given and answers are being sought by available genetic testing technology. It is useful, no doubt, but then we have to be careful. Genetic testing may not provide all answers and think about the consequences. So multi-omics approach may be needed. So is it possible to have a pre-test genetic counseling in the protocol? Post-test counseling through experts. This happens more often after sending the genetic test and getting the report, and there is a dilemma. And then clinical geneticists or genetic counselors, can they be involved earlier for better management? So just to go in brief for an easy recap of that, what genes are. So you have the cell or the genome as a library with the book as the chromosome, and inside you have the chapters where you have the gene and the letters which can be read and be translated into the protein. So as you know, there are multiple levels of packaging of the DNA, and something can go wrong at each stage, though the primary level is the DNA. So seeing the central dogma, it's the DNA into the RNA and the protein, and if you see here that there are a lot of factors which play along, which can be around the gene or away from the gene to regulate it. So variations in the sequence, they can be polymorphisms where the frequency is taken as more than 1% and unlikely to cause the disease, while as mutations which are less than 1%, which can be SNPs, single nucleotide polymorphism, indels, small insertions, or copy number variations. And the sequence change actually will change the whole message, and from the protein you can have a missense leading to progean, or a nonsense where there is truncation leading to just prot, or deletion leading to prion, and petoterane, which is inversion. So each message is changed from the normal. So variations can happen at the nucleotide level or at the chromosome level. So you have aneuploidy structural variants, you have copy number variants. They may or may not be directly related to the disease, but they have a lot of role in gene expression and regulation. So sequence is not enough for a phenotype. You have heard from the previous speaker that there is a lot of environmental factors, and the interaction among these leads to the phenotype. So you have a rare monogenic cause, which can be a simple single gene like cystic fibrosis, unifactorial with a high risk, recurrence risk, whereas you have the more common genetic complex multifactorial polygenic factors where there is a low risk recurrence. So again, there is not only the genetic variation, the phenotype depends also on the epigenetic as well as the environmental factors which affect the physiology and how your lifestyle is, and you then have the phenotype with the where you can precisely target what you are more vulnerable for. So of course you have the common modes of inheritance, the autosome dominant recessive and the X-linked dominant recessive. So the level of detection which can happen can be at the chromosome level, as you all know that there is karyotype where you can detect extra chromosome such as in Down syndrome, or it can be a copy number variation which can be detected by microarray or by an MLPA, or you can go more deeper and do a sequencing, the Sanger sequencing which started off, but now we have the different sequencing tools such as the first generation, the second generation, and the third generation, which can read short reads as well as long read sequences. Now the problem comes where you have to classify what that variant or variation means. So there are ACMG, the American College of Medical Genetic Guidelines for the variant interpretation. This is very commonly cited, a paper by Richard et al. 2015. So till now we have this 5 categories where you have the benign ones and you have the pathogenic ones, and depending on the different aspects such as population database, functional assays, in silico prediction, and literature available, so you can classify them or grade them into different categories like strong, very strong, moderate, benign, or pathogenic. And depending on that, the interpretation happens. So if you have a pathogenic, you need a very strong like PSV1 along with one of the moderate ones, and that way you can classify into pathogenic, likely pathogenic, benign, and likely benign, and a gray area of uncertain significance. So these are the clinically relevant ones, the likely pathogenic and the pathogenic, which are rare. There have a severe protein impact. They are reported in other individual with consistent phenotype. That is why replication is needed. Segregated with the disease in the families. Also can be de novo occurrence in sporadic cases. And there is a functional study which can support the evidence as told by Dr. Atushi before. So also in this category we don't take any clinical action, while in this we have to take a clinical action. But if you see the major area, here is a VUS which have to be classified again, and whether it's relevant clinically or not by different strategies and multiple strategies such as co-segregation with the disease, in silico prediction, severity of the protein modification, biochemical functional assays, loss of heterozygosity, histology. So lot of corroborating evidence has to be there, because the interpretation of VUS is going to impact not only the patient but also the family, the relatives, and the friends. So which test to choose? Of course, you have the conventional cytogenetics, and your clinical criteria and evaluation will give you whether a karyotype is good or whether a fluorescent in situ hybridization or a chromosomal microarray, or whether it's a molecular where you have the numerous PCR method, the MLPA, the nucleotide repeats by triple PCR, or sequencing which can be whole exome or whole genome, Sanger to confirm and validate it, and also optical gene mapping which can do both long reads and as well as repeat sequence apart from the short reads. So all this variant of clinical significance has to be interpreted with the family history, the phenotype, and applying the principles of genetics such as codominance, recessive, meiosis, heterozygous, and the Hardy-Weinberg equilibrium. But when to suspect a genetic disorder, every case may not need a genetic test. So if it is present congenitally or soon after birth or early onset, or there is a family history which can be evident by 3-generation pedigrees that you take, early deaths, inheritance pattern, there can be variability, there can be penetrance issue, there can be consanguinity or dysmorphism. So genetics has really helped in cases where the technology is used, and this was a 20-year-old student with complaints of abdominal pain, and he was the only person in the family to be affected and admitted so many times with that, with loss of weight, and the exome report nicely picked up that there is a pathogenic PRSS variant, and a pancreatitis could be confirmed hereditary. So this was an autosomal dominant, and though we don't have the parents' validation, but probably it's a sporadic. Another case where you have a straightforward case with a 17-year-old male and presented with sensory paresthesias and loss of sensory loss along with pain, ataxia and spasticity. But some smart clinician probed the history and found that the mother had told that the child was having oily stools since 3 months of age, and therefore referred to the clinician who deals with cystic fibrosis, and under a project the testing was done for exome, and then it picked up the pathogenic homozygous compound heterozygous mutation. But the secondary effect of the primary genetic problem, which is the CFTR, leading to malabsorption, decreased vitamin E levels, and presenting as ataxia. So had not it been for the acumen of the clinician, we would have been going on treating for vitamin E deficiency and not treat the underlying problem. The blended phenotype, I'll just highlight a case. This was a case with a 14-year-old who was diagnosed with the neurological symptoms as well as a KF ring positive, and you can see the dysmorphic features, and Wilson's was suspected, and targeted sequencing offered that there was a compound heterozygous variant which were pathogenic. However, on looking at the family history, there was another brother who was having global delay with absent speech, autism, and there was some dysmorphism. He didn't have the Wilson's variants, and he was showing heterotopia on MRI. So thinking that the two brothers, which are different phenotypes, dysmorphic, and the Wilson's response to treatment to Wilson was not adequate for the first brother, an array was done which showed that there is a copy number variation or a deletion in chromosome 5. So this was thought to be in the chromosome 5 like the Cry-Du-Chat region, but the exact coordinates of the CMA picked up that it was a little away from the Cry-Du-Chat region. Then we did the younger brother and we found a duplication in the similar area. So finally we had to go back to karyotype, which is the oldest method of genetic testing, which showed that there is actually a deletion in chromosome 5 but away from the Cry-Du-Chat region, and the child, the younger brother, had an insertion here of the 5 chromosome which was duplicated. So there were 3 small regions of the chromosome 5, and finally the mother's karyotype showed that she was a balanced translocation of the chromosome 5 and 15. So based on that, we have the expanding ACMG variant classification, which goes deeper into chronic pancreatitis, where you have the pancreatitis genes and you have the common genes which have a predominant effect, which can be a gain of function or a loss of function, but there are other modifying or predisposing factors which can lead to lot of variation or the actual phenotype. So the scoring can happen with predisposing and likely predisposing factors along with the likely pathogenic and pathogenic factors, and you can get a risk. So we can say that multi-omics and exposome, to which are the triggers of getting the phenotype, have to be considered. It is a multi-stage test. You may have to look for the test from different levels and also go back to conventional karyotype sometimes. We have multiple genes, modifier genes, variable expressivity, penetrance, and also the environmental component to think about. And challenges in India are peculiar because we have a diverse population with admixture of gene pools. Consanguinity is still prevalent. There are lack of trained geneticists and counselors. There is high cost of diagnosis and high cost of treatment, lack of awareness and stigma, and there is a lack of care for majority of the genetic disorders like such as palliative care, the policies are not adequate for holistic care.
Dr. Danda,
so
are you closing?
Yeah, just a minute. So we can remove the VUS probably by more studies, and when we get to know by more collaboration, and that is why we are here. So thank you so much.